a laparoscopist, colposcopist, ART specialist. She has many academic achievements to her, and she has organized national conferences at Kanpur, WWNatCon 23-24, National President NCD Conference. She has many publications to her credit, and she has also many awards and achievements to her credit. So ma'am has a long list. I should not waste time, and ma'am, I would request you to start your talk. Thank you so much.
Thank you, Chairperson. First of all, sitting here in the holy city of Varanasi, Kashi Vishwanath Shambho, I bow in front of that Almighty God, Bhagwan Vishwanath Shambho. And I congratulate whole of the team of Varanasi who has taken day and night efforts to organize such a beautiful conference. Seniors, Dr. Kiran Pandey Madam, upcoming UPCOG President is sitting here, Dr. Saroj Madam is sitting here, all the seniors, my respects and regards. The topic given to me is homocysteine and pregnancy related complications. Before starting my topic, I just want to ask to all of you, how many of you order for homocysteine levels routinely in the pregnancy or in a special case? There was a famous cover of the Times magazine from October 2010 which shows the first 9 months they shape the rest of the life is about the science of the fetal origin, also called the developmental origin of the health and disease theory. The Barker's hypothesis, this is proposed by David Barker, and suggesting that adult disease may originate in the fetal life. So malnutrition and the other adverse environmental exposure during the development alter gene expression. They definitely alter the gene expression and program the body's structure and function for the life. So the key factor influencing the early phase of life are nutrition and nurture. So how does the maternal diet that affects all this? Maternal diet is one of the main player in this context, as the macro and the micronutrients are direct regulator of the DNA stability and phenotypic adaptation. This, how does it do? It does by influencing the availability of methyl donors and mechanism promoting the DNA stability. So, as I have shown that epigenetic modification that happens by the fetal gene expression as well as the placental gene expression. These both, they help in the fetal development, and there is a nutritional programming. So homocysteine, we all are knowing about it. Homocysteine is a non-protein forming sulfur containing amino acid. It is formed exclusively by the demethylation of methionine during the conversion of methionine to cysteine. So, I have shown this cycle of the methionine to homocysteine and homocysteine to cysteine by the desulfuration, where the SO4 is formed. Here in this cycle, homocysteine is again being converted into methionine. So this process is carried out in the presence of certain vitamins. These are vitamin B12, B9 or folic acid, and B6. In case of any deficiency of these vitamins, there is excess of homocysteine in our blood. That condition is known as hyperhomocysteinemia. So when we say it, hyperhomocysteinemia, this is a normal level is 5 to 15 millimole per liter. While mild hyperhomocysteinemia, that happens when the levels are between 15 to 30 millimole per liter, while moderate is between 30 to 100 millimole per liter, and severe levels if they are more than 100 millimole per liter. So epidemiology that shows that India predominantly follows the vegetarian food habits. Because of this, there may be deficiency of certain vitamin like vitamin B12, which is the main source by the non-vegetarian diet. So there is a higher incidence of hyperhomocysteinemia in India. Etiology of hyperhomocysteinemia, that is as I have just discussed, the vitamin deficiency. These may be the folic acid deficiency, B12 and B6 deficiency, and there may be genetic causes due to certain gene mutations. So, 1-carbon metabolism, it is regulated by the cofactors. These are the folate, vitamin B12 and B6, and the substrate is here methionine, cysteine, and intermediates are SAM, SAH and homocysteine. So, it thus entails pathway that conserve methionine to ensure methyl group availability and removes unwanted homocysteine from the system, as I have just shown in the cycle. So, folate dependent and independent remethylation, as I have just shown, that cycle is the basic thing which you have to again remind in your mind. Folate is a coenzyme in the nucleic acid synthesis and methionine regeneration. So, mild hyperhomocystinemia is usually caused by mild impairment of methylation that is associated with the folate or vitamin B12 deficiency, which is the most common. Therefore, with the start of, I welcome Dr. Anuradha madam here, and which is with the deficiency of thermolability of MTHFR. Choline and betaine represent the essential source of 1-carbon units, especially during the folate deficiency. So, homocysteine level is lower during the pregnancy. Normally, if we see that in pregnancy, this is lower in compared to its normal values. The homocysteine level tend to drop in the first trimester and it reaches its lowest during the second trimester. Thereafter, it increases steadily at the end of the pregnancy until it reaches the level at the beginning of pregnancy. Here is the graph which I have shown. You can see very well the level of the homocysteine during pregnancy. So, elevated level of homocysteine in the blood plasma, that is more than 15 micromole per liter, is a systemic medical condition which is known as the hyperhomocystinemia, as we have just discussed. Now, why we are worried about the hyperhomocystinemia? We are continuously saying hyperhomocystinemia, get the levels done. It affects each and every organ. Regarding the cardiovascular system, it can cause atherosclerosis, it can cause cardiovascular diseases. It is responsible for more and more incidents of heart attacks and even stroke. In nervous system, this hyperhomocystinemia may predispose the patient to epilepsy, dementia, even Alzheimer's and Parkinson's. In sensory organ, this may cause optical dysfunction and acoustic dysfunctions. Reproductive apparatus, with which we all are very much concerned. It can cause sexual dysfunction and many of the pregnancy complications which we will be just discussing. In endocrine system, it can also predispose to diabetes in the persons who are already prone. In the skeletal system, it also affects and cause more of the osteoporotic fractures. In excretory system, in already prone persons, it can cause the renal dysfunction. So, hyperhomocystinemia is responsible for multiple problems. Hyperhomocystinemia reduces the nitric oxide released by the vascular endothelium and causes the formation of the thrombosis and reduced placental perfusion. So, it increases the risk of abortive diseases, preeclampsia, premature delivery, retroplacental hematoma and intrauterine growth restriction. These are the listing. I have already said about the recurrent pregnancy loss, preeclampsia, preterm delivery, placental abruption, fetal growth restriction, neural tube defect, gestational diabetes mellitus. So, if you get any of these conditions, please get her homocysteine level done and supplement with these all things. So, clinical outcome in pregnancy, these may be approximately, there are 2 to 3-fold increase risk of pregnancy-induced hypertension, abruptio placentae, intrauterine growth restriction, HELLP syndrome, even abruptio placentae, intrauterine growth restriction, and there are in pyridoxal 5-phosphatase deficiency, there are increased risk of pregnancy-induced hypertension, which becomes at least 4-fold more. So 53% of the cases remain unexplained in case of RPL. Hyperhomocystinemia has been suggested as the risk factor for recurrent miscarriage due to its prothrombotic effect. It interferes with the function of fibrinolytic enzyme by causing them to bind the lysine residue of the homocysteine. It lowers the production of nitric oxide by the endothelial cell and the platelet. Therefore, it increases the production of ROS. So, serum homocysteine level in the preeclampsia. Preeclampsia was related to 4.5% higher blood homocysteine level and a 1.6-fold higher risk of presenting elevated homocysteine than the woman with uncomplicated pregnancy. This is a very good article which was published in Journal of Obstetrics and Gynae of India, and this says that homocysteine levels are very important during pregnancy and should be done routinely, and look for hyperhomocystinemia. Its results are there which says that hyperhomocystinemia is responsible for preeclampsia, severe preeclampsia, and homocysteine test is easy and less time consuming and can be reliably considered as the predictive marker for the pregnancy induced hypertension. This is another study in hyperhomocystinemia with the pregnancy loss, and it says that high homocysteine level detected during the early weeks of gestation can be a warning about the miscarriage risk and may also provide insight about the obstetric complications that may develop in the further weeks of gestation. So, when to screen for the hyperhomocystinemia? Values in early pregnancy. As soon as the patient arrives in the first trimester only, you should get it done. Second trimester plasma homocysteine concentration do not predict the subsequent development of pregnancy-induced hypertension, eclampsia, and intrauterine growth restriction. So, how to treat? Treat with homocysteine lowering therapy. What is this? That's already discussed. These are the vitamin B6, B9, and B12. Folic acid and cobalamin supplementation ensure that methionine synthetase cofactor stores are adequate, thereby promoting normal tetrahydrofolate metabolism and demethylation of the homocysteine to methionine. So, folic acid in hyperhomocystinemia, adequate folate status is needed. Supplementation with the folic acid in the amount of 0.5 to 5 milligram per day has been found to reduce the homocysteine level by around 25%. These are the food products which are a good source of the folic acid. These are the cauliflower, asparagus, broccoli, leafy green vegetable, okra, mushroom, avocado, beetroot, papaya, oranges, seeds, nuts and beans, and the pear lentils. About the vitamin B6, it reduces the level of homocysteine by process of transsulfuration to cysteine, and hence related pregnancy complications are reduced. Vitamin B6 level of the mother at the onset of the pregnancy have a positive correlation with the birth weight of the newborn. So, usual therapeutic dose of pyridoxine does not have teratogenic effects, so that should be supplemented. These are the natural sources of vitamin B6. Primary natural source of vitamin B6 are the animal products as well as the plant products. Animal products are the liver, chicken and fish, while the plant products are chickpeas, nuts, bananas and oranges. So, vitamin B12 deficiency, folate is trapped as unstable MTHF, causing functional folate deficiency. Vitamin B12 deficiency is more common among the Indian pregnant women as compared to folate because the main source is non-vegetarian. From vegetarian source are almond, cheese as well as the milk, while there are so many non-vegetarian source: fish, crab, chicken, egg and the red meat. So, this was a very good article on the folic acid and vitamin B12 supplementation which is needed in pregnancy, otherwise there is hyperhomocystinemia. Why active forms of vitamin B12? These all vitamins is needed. This is very important because these all active form of the folic acid, B6 and cyanocobalamin, they are available in the tablet forms also. synthetic folic acid is converted into dihydrofolate, then tetrahydrofolate, then 10-formyl THF and 5,10-methionine THF and 5,10-methionine THF and ultimately 5-MTHF. So these active forms are freely available in the tablet form. You can supplement in these form, and they are stable in body's environment also. So active forms are more readily available forms of the vitamin B12. What is the take home message? Impaired homocysteine metabolism is an important risk factor in the pregnant woman. Hyperhomocysteinemia is associated with several pregnancy related complications, as we all have discussed. At present, homocysteine test can be considered selectively in the patients with high risk or women with a poor maternal history. Vitamin B supplementation should be considered from early pregnancy to reduce the complications associated with hyperhomocysteinemia. Especially, we should think about the supplementation of active form. The best way to predict your future is to create it, by Abraham Lincoln. So, thank you very much. Hope we will start doing more of in our patients wherever needed homocysteine levels. Thank you very much for the patience.
So, but does the guidelines recommend hyperhomocysteine levels in bad obstetric history, ASHRAE or ASRM, in the panel of RPL?
I think I have searched that in X-ray there is that you should do the homocysteine level. Just search it.
Thank you. Yeah.
Thank you.
Thank you so much. Thank you so much, ma'am. Our next renowned